Hello, welcome to the Voice of Nursing. My name is Adrian Tracy, I'm the CEO of ICG Medical. Today we're very lucky to be joined by Dr. Terri Porrett, a specialist nurse, as she'd like to be introduced. Terri, welcome. Thank you for joining us. Terri, it'd be great to get a little bit of your background, how you joined nursing and then throughout your career, and then some of the other things you're doing.
Okay, well, hello, my name's Terri Porrett, and I'm a nurse. I always wanted to be a nurse. I don't know why, because I have no nurses in the family, but from the age of 5 I was going to be a nurse. I honestly really didn't understand what it was going to be, what it was about, but I just knew I should be a nurse. And I went to a convent school, and the nuns were really supportive of this, and Sister Martha in the playground allowed me to apply the magic cream to people's grazes if they fell over. I then discovered, once I started my nurse training, that this magic ointment was actually zinc and castor oil cream, and not in the least bit magic. But that really made me, yes, this was what I wanted to do. So I did my nurse training at the London Hospital in Whitechapel. Before it was Royal, it's now the Royal London Hospital, and I absolutely loved every minute of it. During my nurse training, the second ward that I worked on was a surgical ward, a colorectal surgical ward. And it was people with complex bowel problems that were having surgery that resulted in them having a stoma bag, a colostomy or an ileostomy. And in those days, manufacturing wasn't fantastic, and these were clear plastic, rustly pouches which leaked a lot, and there was odour associated with them. And I thought, how do these people manage when they go home? We have to do better, and this is what I want to do when I qualify. Well, I want to work in this field, and we can do this better. So when I qualified, all of my staff nurse experience was around colorectal. I worked on a medical ward, gastroenterology medical ward. I worked on a colorectal surgical unit. I then spent a year in the colorectal theatres, because I thought, if I'm going to really be able to explain and support somebody having surgery, I need to understand what colorectal surgery is all about. So something simple like a patient who's going to have an abdominal perineal excision of rectum would always complain, after surgery my legs hurt, and you'd think, you've had a major operation and you're complaining that your legs hurt. And then I worked in theatres, and I understood that for a significant amount of time their legs are up in stirrups, hanging in stirrups. So of course, actually, but I could explain that afterwards, before the operation, to allay people's fears, because they thought there was something was wrong, because nobody had told them that their legs might feel uncomfortable. So I did that, and my aim was to be a ward sister at St Mark's Hospital, and St Mark's Hospital was in City Road, just down from Moorfields, and it was the country's really specialist colorectal hospital, where people were referred from all over the country, and that was my plan. So luckily I became a ward sister on Allingham Ward at St Mark's, but I didn't have a plan after that, because that had been my focus. So I was a ward sister for 5.5 years, I think, at St Mark's, and whilst I was a ward sister, I did some specialist training to be a stoma care nurse, because obviously at St Mark's a huge percentage of the patients, because it was bowel surgery, had a stoma. And
what is a stoma? Just for
a stoma.
Not in the,
okay, a stoma is a section of bowel. So a colostomy on the left is large bowel, brought to the surface of the abdominal wall and stitched. And so the feces comes out of the stoma into a pouch, which is worn stuck to the abdomen. And on the other side, it's called an ileostomy, and that's small bowel. But the principle is exactly the same. And there is also urinary stomas. If you have a bladder problem, the process is exactly the same, and so you have a stoma and urine comes out of it. I went to the Homerton Hospital from St Mark's to work as a stoma care nurse specialist. And in all honesty, my plan was to go and set up this service at the Homerton for a couple of years and then come back to St Mark's. But the Homerton, where I went, is just a fantastic hospital, really, really flat management structure. The chief executive was a nurse. I was there for over 20 years, and so I started as a stoma care nurse. I became a colorectal nurse, I became a nurse consultant, and the last few years that I was there, I was clinical director for the North East London Bowel Cancer Screening Programme. So yeah, that 2 years flashed by, but I absolutely have loved every minute of it, because stoma care is incredibly challenging. It's challenging for the person having the surgery because it's a huge change to your body image. As a society, we attach huge stigma to bowel and bottom problems. We're not great in this country about talking about things. We have that carry-on kind of whoopee cushion kind of humour, and we laugh, and that makes it very difficult for people with these conditions. It's you know, many people would consider it's like having a hidden disability, but actually it does impact for some people on how they can live their lives. So that's a very short potted history of my nursing career to date.
So you had a very successful career, you know, noted. But I remember we spoke about just off camera before, you didn't want to go down maybe the chief nursing route or the director of nursing route, which is, you know, a traditional maybe career path that lots of nurses go to or aspire to be. You went through a slightly different path, which would be really interesting to hear about the impact.
Yes, don't get me wrong, there's nothing wrong with chief nurses and directors of nursing, they're fantastic, but it just wasn't what I wanted to do. I felt that I could develop as a nurse and develop and use my expertise to impact change, to make developments in clinical care for patients with colorectal and bowel problems. So it was something I studiously avoided, if I'm honest. I think that being a director of nursing or chief nurse is an extremely difficult job. You're juggling so much, but also you're juggling a political and policy agenda that you have to work to as well. And that wasn't. I'm not particularly good at diplomacy, as many people who know me. So that really, I wouldn't have been a very good chief nurse or director of nursing. But I think that I've always believed that if as a nurse you can see that you could do something differently and it would improve care for patients, that we should have the confidence to say it. And so I've always felt that as a clinical nurse I could have as much impact and change the landscape in my particular little area of nursing far more than potentially a director of nursing.
Didn't you do this quite early in your career?
Yeah, well, when I was at the Homerton Hospital as a stoma care nurse, I went and spoke to our fantastic chief executive, Nancy Hallett. She's retired now, was the director of nursing, and said, I have noticed something that I think is probably not right, that if you are unfortunate enough to have bowel cancer, and you have your bowel cancer surgery, and unfortunately the surgeon can't join your bowel back up together, and you have a stoma, you get me. And I follow you through your pathway, I give you advice about your chemotherapy, I make sure you don't fall through the cracks in any services. But if you're unlucky enough to have bowel cancer, you have your operation, but you're fortunate enough to be joined up, at that time there was nobody then to help navigate you through a complicated system. And I went to her and said, I actually think the stoma care nursing service should support colorectal patients in general. So if they haven't got a stoma, that doesn't mean they don't need the support and advice with their bowel cancer that somebody with a stoma does. And I was fortunate enough that she said, yeah, I think you're right. She appointed somebody else to work with me so that we could look at developing the role. We could talk about it. We could promote it. The Royal College of Surgeons Association of Coloproctology supported this development of colorectal nurses, and now there are colorectal nurses in every acute trust. So you don't have to have leader, you don't have to have manager, you don't have to have chief nurse in your job title or your name badge to actually make changes within the clinical area that you work that benefits patients.
I think as you come back to the care element, if you're on the front line and you see something wrong, it's the nurses who go, this isn't right, we can help you.
Yeah.
I know one of the things we were discussing about care being a big thing, and one of the challenges of basic care versus fundamental care.
Don't get me started on basic. Nursing is its own worst enemy, unfortunately. We dumb down all the time what we do. I just do this. I supported the doctor. I helped the doctor do that. Yes, it's basic nursing care. Actually, there's nothing basic about care that nurses give. It's fundamental to which all the other care is pinned. It's the absolute foundations of everything else. So there is there's no basic nursing care. It's fundamental nursing care, and I think that it's understandable as the nursing profession developed from religious orders. It was a predominantly, and not so much now, but predominantly female profession. So it was seen as very much vocational. You didn't need to think. You needed to diligently do what the doctor instructed you to do, but in a caring way. But actually, obviously, that's not the case now, and research shows, as we discussed, that actually patients' outcomes are significantly better the more experienced, the more senior the nurses looking after them, and that's why the whole issue of safe staffing came about, because without a certain level of expert qualified nurses, people's outcomes are not as good. So I think as nurses we are our own worst enemy. We don't big up what we do.
And I think you're trying to help that and share some best practice of fundamental care.
Exactly. So I'm really fortunate. So my job at the moment, I work for Coloplast, and Coloplast is a market-leading developer of ostomy products. So pouches and supporting products to allow people to live the life they want to live. And I am their head of education for their ostomy division. So actually using actors and prosthetic simulations made by an incredibly clever lady from the film industry who does all the kind of prosthetics in films. We make complicated stoma problems, and nurses interact with the actor who's learnt the history and the part and becomes that patient, and then they actually work on the abdomen and find a solution that solves the problem, sticking on pouches and whatever. But also, that's fantastic. Yeah. And then working with Ulster University, we have some degree level pathways for specialist nurses. But we also have developed the Apollo Nursing Resource, which is a standalone website which Coloplast and Ulster University financially supported, and Professor Alison Leary, who I'm not sure if you're familiar with, but Professor Leary is a nurse who has a phenomenal brain for numbers. So she was a clinical nurse specialist working in the lung cancer field, but now her work is all about analysing data around safe staffing, around outcomes, around the hidden value of nursing interventions. And she worked with us to develop the resources on this website. So Apollo gives specialist nurses the tools that they're not taught when they do their specialist clinical courses. Okay. So when I was a specialist stoma care nurse, I pretty much knew about stoma care. But the first time I was asked to do an annual report, what's that? How do you do an annual report? Nobody's taught a nurse how to write an annual report. Nobody had taught me how to write a job plan. Nobody had taught me how to do a service summary. And actually, we need to be accountable. We need to demonstrate what we do. But actually, nobody had given us the tools to do it. So the Apollo website has a job planning app. It has templates and examples of annual reports, business plans. It's got Cassandra, which is a tool for actually evaluating the key components of your job. So that's I really enjoy doing that, because specialist nurses have absolute hidden value. And if we don't help specialist nurses to demonstrate the hidden value of their role, then they could become extinct. We're in a huge financial crisis. Specialist nurses are expensive. They're a band 6 or a 7. And we don't want that to happen, because actually the added value to somebody with a stoma and the ability for that person to live their life is massive. So the Apollo Nursing website is there, but it's not just for colorectal stoma care nurses. Any specialist nurse can use this. Tissue viability, diabetes. We have consultant physios use it, ward managers use it. So although it started specifically for specialist nurses, it's actually used the tools are used by a wide range.
I was going to say, would a general nurse be able to look in there and get a bit of a feel if they wanted to get into a specialist area?
Yes, absolutely. And would be able to reach out via the website or on Twitter. I'm interested in being a diabetes nurse. Who can help me here? What do I have to do? What's my career pathway? What experience should I get to put myself in the best position to get into this role?
Fantastic.
So it's freely open to everybody. You don't need a password. If you put in Google Apollo Nursing Resource, it comes straight first on Google. So that's fantastic. So in my day job with Coloplast, I get to empower and support specialist nurses. And in my non-day job, it's not a hobby, it's very important, and it's a website that enables frontline health staff, health and social care, whether you're a nurse, whether you're a physio, a doctor, social worker. This is a forum for people to share the solutions that they found that work for them in their clinical area. Because actually, if you've got a problem with noisy bins and you're in your ward and you're getting constant complaints in the patient survey that the ward's noisy at night and people can't sleep, you're not the only ward. If you've got a solution, share it with us, because there will be lots of wards up and down the country that occasionally get on their patient surveys, it's too noisy, I'm not sleeping very well. If I'm tired, how am I going to get better quicker? So people share what would be considered little things. But actually, we believe that the little things are in fact the big things. And that if you have a solution that works in one ward that either improves patient experience or saves money. Say on one ward they're saving £100 a month because they've done something differently. If you share that, and we can look at that being replicated across thousands of wards around the country, that's when that cost efficiency saving to the NHS becomes a really, really big thing. So we have to save money at the moment in the NHS, but actually we're not going to save it probably by doing one thing that saves £20 million. But we probably can do it by frontline staff sharing these supposedly little things that actually are cost effective, cost efficient, and if replicated around the NHS, will save a significant amount of money.
Get that best practice across.
Absolutely. So the Academy of Fab staff, in fact, we've just had a summer makeover. So if you've looked at the website before, go look at it again now, because we've had a summer makeover, new animations, much easier to search and find things that interest you or from your specialist area. So yeah, have a look, please. And it gets around 2,000 page views a day. There's over 3,500 shares of things that have worked on the website for other people to go and look at. And our big thing at the moment is Fab Change 70, which is a development of Change Day in the NHS, where people in the past have pledged to do something differently. This year, between October the 17th and the 19th, we're saying to people, go look at what's happening in your hospital and pledge to share it. Share what you're already doing. Don't pledge to do something different, because you're doing great stuff. But quite often we get invited to visit, we call it Fab on Tour. And quite often hospitals will invite us, and at lunchtime they invite staff to a marketplace. So wards or units can ask to have a table and a poster board, and they tell us about what they're doing. And people like to tell people what they're doing. They're proud of their wards or their services or their units. And quite often, so we will go around these 20 or 30, stand and listen, and amazing stuff which they will share on the website. And quite often, people within the hospital will say, do you know what, I work in surgery and I had no idea that they'd fixed this problem in the Division of Medicine. And I've got the problem in surgery and I'm trying to find a solution. And we found it. But nobody told me. So in large hospitals, they don't even know within that large hospital and the different divisions solutions that people have come up with that they could use. So there's going to be a 70-hour digital celebration and sharing of these great things, and it's going to make a time capsule. This is the NHS at 70. This is the fab stuff that frontline staff are doing.
Real collaboration.
Yeah, it's great. So I'm very fortunate and very privileged, actually, to be able to do this.
And tell us a bit about the story about patients trying to go to the toilet in the evening, at night.
Recently.
Which I thought was tremendous.
I believe it's a student nurse on a ward had worked out falls occur more at night. And she went, you know what, my son had this problem at night getting up. We've got these shiny stars and we put them on the ceiling, but you can get footprints that glow in the dark. And so they've done this Donna's glow-in-the-dark project, and this ward now has the glowing footprint. You can have glowing strips around the light so that people know how to push and turn the light on. How good is that? And already people are seeing that and contacting and saying, right, how did you do it? Where did you order the things for? What's the protocol for it? We want to do this. Now, if Donna's idea, and I hope your name is Donna. I've put so many things on the website. I'm sure it's Donna. But if not, whoever this fantastic nurse was that went, actually, we can do something about this. We can stop making it difficult for people at night without keeping the rest of the ward awake. You don't have to have all the lights.
No, not at all.
Let's use what I use with my children. Perfect.
It's a great idea. That's what I use with my kids.
It's absolutely brilliant. But it's humbling, actually, that people are working under huge pressure in the front line, in the NHS, and not just the front line, but back office staff that people don't see, and you know, so all the admin staff, all of the clerical staff, portering, catering, under huge pressure, that they take the time to either invite us to come and visit or to share their amazing work on the website. It's very humbling because, you know, I've never met anybody that works in the NHS that wakes up in the morning and goes, right, what am I going to go to work and mess up today? What appointment am I going to miss? What notes am I going to forget to pick up? Nobody. People go to work to do good job, to care for patients, whatever their vital role in the spoke of care. So the patient's in the middle, and all these spokes make the wheel go round. Nobody goes to work with the intention of not doing a good job. And these people are finding solutions to what are considered little problems within their work areas.
What do you know, looking at the current state of nursing, what would you think the biggest challenges nurses are having at the moment? And then following off that, what you think the future might look like for nursing?
Yeah, well, I think fundamentally nurses are exhausted. I think that the winter was incredibly difficult for hospitals, and we all saw the news footage of people in trolleys in A&E departments. There is huge pressure, and staff are tired, but they want to do a good job. And so we have to support them psychologically to be able to do that. We have to care for our staff better than we do at the moment, in my humble opinion. We need to allow staff to feel that their knowledge or insights are valued and that they can make a change in the environment that they're working. We absolutely need to recognise that safe staffing is essential. The pressure for qualified nurses being on their own with acutely sick patients and being the only qualified nurse on a ward, the stress levels are huge. We need to address safe staffing. We also need to address retention of staff. People are leaving, people are taking early retirement, and people are leaving within a very short time of qualifying into whatever allied health profession they chose, because the work environment is so stressful. And I believe that we do unfortunately have a culture where we're very good at telling people where they're missing a target or not doing good enough, and we have a really, really poor culture about saying it was a difficult day. I know we missed getting Mr. Jones to his outpatient appointment, or he didn't get out of bed today because we didn't have enough staff. But actually, A, B and C got done really well. So thank you. How can I work with you tomorrow to make sure that Mr. Jones does get out of bed? We don't do that. We just hit people with a big stick and tell them to work harder, and we don't give them the tools to work smarter and better.
I think the problem with clinical staff, as you rightly mentioned, is that they're supposed to be seen as infallible. And they're human. They get tired.
Absolutely.
They make mistakes. You can't be perfect all the time in any industry, but healthcare is one of those ones where it's very challenging. And the mental health side is a big thing for nurses. They're under and doctors and anyone else in the healthcare profession. They're under so much pressure.
Absolutely.
And it's a big thing that keeps coming out as we talk to more people. Is the mental health aspect.
Absolutely. We are not kind to ourselves. We have a culture where still people don't feel safe to speak out. So if we don't feel safe and confident to talk about near misses, things, untoward incidents that really shouldn't have happened, but didn't result in significant harm to anybody, but was an adverse incident. It shouldn't have happened. If we can't talk about those and learn from those, then we can't prevent them from happening again. But staff feel it's difficult to speak up about things. I think until we have a culture where we understand that we learn from near misses, we learn from mistakes, we learn from never events, so that we actually make them never events, because we have things that are classed as never events, but they still happen. And if a never event happens in a hospital, say they leave a swab or an instrument inside somebody's abdomen during an operation, they will have a very, very formal process of how they will work out how that happened, and then they will formally put things in place within their trust to make sure that never happens again. That's brilliant. Tell everybody else about it, because I don't want my hospital to have that never event to then do the same learning you did. I want to prevent it happening. So we are frightened that we might get the blame, we might be disciplined, we might be suspended, we might be struck off, we might be classed as a troublemaker, a whistleblower who's got an axe to grind, and so we don't have that safety culture that the airline industry has. I would suggest that the more near misses, the more untoward incidents that are documented and investigated, the safer a hospital is, because that shows they have a culture of actually discussing this and learning from it. We need a no-blame culture if we're going to improve safety, but also staff morale in the NHS.
Yeah, and I think Matthew Syed's written a book about that, hasn't it? Black Box Thinking, which is all about the aviation industry and how when things go wrong, they don't blame, they just try and improve. Exactly. I appreciate it's different in healthcare because it's human beings and it's not engineering. There's a slight difference there, of course.
Yeah.
But as you say, it's not something you don't publicise your mistakes.
No.
Whereas if you publicise them, maybe some wouldn't happen if they're more brought to the table.
Absolutely, but we don't do that. We don't learn. We don't have an open culture. There's this always background blame. We're looking for somebody to blame. No, let's look at how we can prevent this happening again in the future. So until we stop the blame game, we're not going to improve. And I think nurses do feel concerned that they may see things happening on a ward or a unit or a process and feel unable to speak up about it because they're concerned about being blamed or being classed as some kind of troublemaker.
And what do you think the future of nursing looks like? What's the next 5-10 years look like?
Well, the next 5 or 10 years, without a doubt, is going to continue to be challenging because of the austerity and recruitment and staffing issues that we currently have. But actually, for nurses, the future is bright. We have huge opportunities in times of adversity to actually demonstrate the value of what we do, the value of preventing of our care, preventing delayed discharges, of preventing readmissions, of empowering people to be able to be productive members of society again. I think if we get into the habit of talking about and demonstrating what we do, and our value is truly understood, our future is incredibly bright because we are cost effective, we are cost efficient. We just need to let people know. But also, on a personal level, it's the most satisfying, fulfilling job to have. I've never once woken up as a nurse, I don't want to go into that, I don't want to go into that, I don't want to do this. It's a fantastic job. So the future's bright. If you want to be a nurse, now is a fantastic time because it's innovation, it's thinking differently, it's coming with a new set of eyes with really wide vision. And you can make a big difference.
And what would you recommend as in a pathway? Is it, I know you've obviously the degree level, or is it looking at HCA, moving into that nursing associate role? I know there's different opinions on how you get into nursing nowadays, so I think there are a few more options available.
That it's right that we should have a wider routes to get into nursing.
Because it's still very difficult to become a nurse.
Yeah, I mean, when I applied to London hospitals, and I know you'll find this hard to believe looking at me, but I started my nurse training in 1979. I know, I don't look old enough, but back in the day, I didn't train at a university. It wasn't a university training. I applied to the Princess Alexandra School of Nursing, which was attached to the London Hospital. I also had interviews at other London hospitals, Barts, St Thomas's. And you had requirements, so a bit like getting into university, you needed a minimum number of A-levels and O-levels to apply. And that was the process, and that was the only process. But I think that misses out on a cohort of people that may not have reached that educational requirement at school for many different reasons, who would be fantastic nurses and who want to be nurses. So I think we should have different entry routes for people. I think we should be really embracing mature nursing students into the profession, because at 18 I went straight from school. 3 weeks after finishing in the sixth form, I started my nurse training. I had no life experience and life skills. And actually, I think that people who are more mature and have life experiences really have a huge amount to offer to the patients that they're looking after. But I do believe that fundamentally, nursing is a profession that, yes, you have to be caring, yes, you have to be compassionate. The 6 C's absolutely are values that should underpin nursing. But a caring nurse who isn't educationally trained may not notice that actually people are deteriorating and are becoming clinically unwell. They may not understand they're taking their blood pressure on a regular basis and seeing it dropping and somebody's pulse rate rising. But if you haven't got the education, you will not realise the potential impact on that patient. So values of caring and compassion, courage, all of those are incredibly important and have always been really strong values in nursing. But you need skills and education to underpin those. Mm-hmm. So I believe that we need registered nurses. We need nurses who have a degree training, but not everybody wants to go down that line, and there are other ways now of becoming a nurse or developing your role in as a healthcare associate. So I think that the wider entry points are good, but the bottom line is you have to have experienced nurses working alongside other healthcare professionals or other healthcare workers to ensure safe practice and appropriate clinical management for patients. But we mustn't forget the fundamentals of care, which are essential. So I'm sure everybody's heard recently about NPJ paralysis, so about the importance of getting people out of bed, about potentially getting people dressed psychologically, how important that is for people.
This is the pyjama paralysis,
NPJ paralysis. Now, that was something that we've always done, but we've kind of lost the understanding of why that's important and the benefits to patients, and about preventing deconditioning, especially with frail older people in hospital. So these initiatives around care are really, really important, but at the same time you have to have an educational and skills base to underpin safe clinical practice.
Agreed. Terri, tell us a bit about yourself. What do you do outside of work, if you've got any time whatsoever, with these many jobs and websites you're doing?
My biggest hobby is the Academy of Fab staff, and I have a pet therapy dog called Alfie, who's a little Bichon Frise, and I got Alfie for my mum. My mum had dementia, and obviously I'm a colorectal nurse. I knew nothing about dementia, so I had a steep learning curve on Twitter and social media, reaching out to people to actually help me. And my mum used to have a dog, Bichon Frise, and I was advised, get another one, allow her to care. She'll remember how to care for the dog because she had a dog. She will be able to accept care and support herself more readily because she is caring for Alfie. And I thought, I'm not so sure, and that's going to be extra work for me, but we rehomed a 3-year-old Bichon, and the change this dog made in her life for over 3 years was absolutely incredible. And when my mum died, I thought, well, actually, power of pets in environments like that is massive. So we did the kind of little pet therapy training, and we both passed our little test and became pet therapy visitors. And so I love doing that. It's fantastic to see people's reaction, how somebody that's anxious or agitated can immediately relax and calm down just sitting and stroking a dog. So again, it's a real privilege to be able to do that, and a little legacy for my mum. So that I do that in my spare time. And my main hobby is photography, so I'm very uncomfortable being on this side of the camera because I'm usually on the other side. So I love photography, and I make quite a lot of films that go on the Fab website, and that pretty much takes all of my time.
A bit of sleeping in this at some stage, occasionally.
Used to 6 hours now. I used to really need 8. Now I'm okay with 6. I think that's an age thing as well.
I think you're doing too much to have 8 hours. So it's. I just feel incredibly privileged to be able to do what I do, and I love every minute of it. You can tell that. No, I think it's great to have you on. Let us know where we can find you. Give us all the links.
Oh my word, okay. On Twitter, me personally, I'm at GBTPO. On Twitter, the Academy of Fab stuff is Fab NHS stuff. And we also have a Facebook account, and we do have LinkedIn, only I'm not as good at LinkedIn. I've already been told I'm not as good at LinkedIn. So
it's all right, you're on Twitter, we'll find you there. And
the website, it's www.fabnhsstaff.net, and Apollo is www.apollonursingresource, all one word, .co.uk.
Fantastic.
I think it's com.
Please get on those websites, let's share as much as we can. I know we've got a lot of nurses going out, and if any nurses are looking to change in their careers, let's get on the Apollo Nursing one and look at what they can do, because I think those are great support networks on both areas. You know, if we're investing in those or getting onto those websites, I think it's only going to improve patient care.
Absolutely. And the key thing, never underestimate the importance of the difference that you make every single day.
Superb. Terri, thank you so much for joining us. Thank you to all our nurses, our healthcare assistants, our doctors for looking after us all. Thank you for joining the Voice of Nursing. We'll catch up with you soon.